We have several great speakers tonight who will discuss some of the treatments available to people who are struggling to maintain a balance in their lives during this pandemic. After their presentations, they will spend time answering your questions. So please use the chat areas and spaces provided on the screen to write your questions. Leading the discussion tonight will be the great Bonnie Buchan. Bonnie has been involved with NAMI for many years, and she is a licensed marriage and family therapist in Carmel. And with that, I thank you for joining us, and I'd like to turn it over to Bonnie. Have at it, Bonnie.
Thanks, Joe. Hi, everybody. Good evening. It is so nice to be with everyone tonight, and such a privilege to be a part of yet another good NAMI program. So one of my favorite things about NAMI is NAMI's always deciding to go try to not so much push the edges, but definitely bring consumers and families and clinicians new ideas and new ways to serve the community. And so I'd like to share with you guys the way this came together. So one of the NAMI board members, whose name is Rory Gomez-Ahrens, called me because she decided that she wanted my opinion about whether or not NAMI should offer, NAMI Monterey should offer neurofeedback as a topic at our state convention. And our local neurologist, Dr. Stella Lagarda, who's going to be speaking tonight, we thought she might be a really neat addition to the state convention. And I thought that was a great idea. And from that conversation came the idea to offer other evidence-based modalities that are non-medication based, that are brain-based and body-based and body-mind based. And so we decided to start to share this not only at a state-based level, but at a local level as well. And that is how both Meg Grundy and Jody McLean became a part of this panel. Meg and Jody are two really qualified, long-term, very special practitioners, clinicians that we have here in our area as well. And so what NAMI decided to do was not only contribute to our state convention, but to everyone here locally. And so they decided that they would come and talk to us about what they do here, about who their clients are, and how they can share and help to heal mental health conditions and serve us all. So one of the things that we want to say before we get started that's really important is that if you are under medical care for your mental health condition, this is not a substitute. It is really important that you talk to your medical provider before you embark on these treatments. Now, these are evidence-based treatments, and what that means is these are research-based modalities that are shown. These are highly effective treatments that bring about healing. They bring about change in the body and the mind. But it's really important you take really good care of yourself and you get consultation. So with all that said, please take really good care of yourself. And we at NAMI believe these are things that are really worth exploring. And Meg, Jody, and Dr. Lagarda are three people that we believe are bringing really high quality treatments to the area. So Dr. Lagarda is she is a board certified in psychiatry and neurology. And she has been at Montage here at CHOMP for 13 years. I mean, since 2013. And she has written in peer-reviewed articles and books. And she is going to be speaking about how neurofeedback not only helps with post-traumatic stress, but she specializes in seizures. Neurofeedback helps regulate the brain when it's dysregulated. And so she's going to talk about how it actually helps in getting the brain re-regulated. It helps with anxiety, headaches, depression, all sorts of other things that benefit people with mental health conditions. ADHD is another big one. And Meg Grundy is a licensed clinical social worker, and she has been in practice here about 15 years. And she's going to be speaking on EMDR, which stands for eye movement desensitization and reprocessing. And so Meg is going to be speaking on its effects on trauma. And so we're going to be talking tonight a lot about trauma and PTSD. And Meg is also a specialist in OCD and anxiety. And she's also probably going to be speaking some, I would imagine, on how EMDR can also help with OCD and how it's affected by trauma as well. And EMDR helps with lots of other things too. It helps with depression. It can help with pain. It can help with anxiety. It's also being used in eating disorders and addiction and other things as well. And so Jody McLean is an applied polarity practitioner and a somatic experiencing practitioner. And Jody is going to be speaking on how trauma lives in the body and how somatic experiencing, which is a body-based trauma resolution modality, is used to help resolve trauma. And she's going to be talking about Dr. Peter Levine's work. And she has been working with him for, I believe it's now 15 years. And she's been in private practice here in PG for 15 years. So we've got a lot to look forward to tonight. And I want to say thank you very much to all three of you for coming. I also want to say thank you to the NAMI board and to all the volunteers at NAMI for having this happen. I also want to say thank you to Voices of Monterey Bay for being a part of this, and to Julie for helping with all the technology and for setting us up. So with that, tonight we're going to lead off the panel with Meg Grundy, and she's going to start us off with EMDR.
Awesome.
Thanks, Meg.
Bonnie, thank you so much. I too want to thank NAMI Monterey and Voices of Monterey. It's really a pleasure to be here tonight and talk about something I'm so passionate about, so excited about. So again, my name is Meg Grundy, and I'm a clinical social worker in private practice on the peninsula. And I've been practicing for over 25 years. 15 of those have been here locally. And, you know, my practice started as a general practice, like many of us do. And I just started working and seeing more and more folks struggling with trauma. One of my colleagues had recently been trained in EMDR, which I'll explain what that is in a minute. But he was someone whose opinion I highly valued. And he told me, he said, Meg, this modality is so effective. I just think that, you know, every clinician should know how to do it. And so, you know, that's all I needed to hear. And I did some research, and I found someone who trained in attachment-focused EMDR, which was just a really good fit for me. So to get into what EMDR is, EMDR stands for eye movement desensitization reprocessing. And I always kind of jokingly say, it needs to be rebranded because who knows what that even means. Well, what it means is, what it stands for is the eye movement piece. This was discovered by Francine Shapiro in the late 80s. She took this famous walk in the woods. She was a psychologist, and she was just really curious about treating trauma and how to best approach it. And she was taking this famous walk in the woods, and she was thinking about a traumatic memory. And she found that if she looked to the right and looked to the left and repeated that motion, that her experience of the trauma shifted. And she got really curious about it. And she developed a modality that has been used for 30 years. It is endorsed by Veterans Affairs. It's a grade A, evidence-based, empirically validated therapy. And, you you know, it's here we are now today with this wonderful tool. And so she found that, Francine, who created EMDR, found that once you focus on a traumatic memory and you move your eyes back and forth, it activates a very rapid processing of information. So here's just a little neurobiology of trauma. So we have two hemispheres in the brain, right hemisphere, left hemisphere. Traumatic memory is stored in the right hemisphere of the brain. And I kind of picture it as like little ice cube trays of, you know, frozen memory particles. And we all can relate to having an experience of getting triggered by a traumatic memory. Let's just say, you know, you experienced a car accident and it was pretty, you know, it really shook you up. This was maybe an accident that, you know, you're crossing through an intersection and you get sideswiped and it's just out of the blue. And you're in motion, your car's in motion, and you're hearing the screeching brakes, you're smelling the tires spinning around and screeching, and all of these sensations, all of these noises, all of the emotions that you're going through during the car accident, they get frozen in the little ice cubes in the right hemisphere of the brain. So then fast forward, you heal from the accident, you get a new car, everything's fine, but you're driving down the road and you hear some brakes screeching, or you smell, you know, some tires, you know, you smell you hear something or you smell something that brings you right back into the traumatic memory. Well, in that moment, those ice cubes, they defrost, and they defrost like that. And what I mean by that is it's like a PTSD response. All of a sudden, you are back in the memory. And your day may have just been going fine and nothing bad was happening, but you heard those sounds and you smelled those smells, and it just woke up all of the traumatic memory. And, you know, some people can, you know, they report like, I just felt like it was happening all over again in real time, because that's how traumatic memory is stored. It's stored in real time. And so it's stored in the time that the trauma happened. And so you're in real time, but you're also experiencing something that happened in the past, and it can be very distressing. And so what EMDR so beautifully, and even to this day kind of mysteriously accomplishes, is a way to get into traumatic memory in a way that doesn't re-traumatize the person. And through that eye movement, the moving the eyes, that was kind of the, that's one way of doing EMDR. But it's through stimulating the right hemisphere and the left hemisphere, whether it's through eye movement, through tapping. Some people use tapping to stimulate right brain, left brain. And some people hold buzzers that stimulate the right brain, the left brain. But what it does, when following a certain kind of script and a certain way of doing EMDR, we can get into the traumatic memory, and we can kind of bridge through the bilateral stimulation, bridge the traumatic memory with the outcome. So taking you back to the car accident where, you know, bam, you get hit, unexpected. You think, you know, is this it? You know, am I going to lose my life over this? So that's all stored. And with EMDR, we're able to get into what's real and true. You survived, you recovered, you got a new car, everything's fine, we've moved on. So what it does is it essentially integrates the right hemisphere and the left hemispheres of the brain. And it brings down the distress of the original trauma. So that's my favorite way of explaining the effect of EMDR, because I think we can all relate to kind of I don't know, I'll call it kind of an everyday trauma like that. Now, EMDR is also helpful in working with not just recent trauma, like a car accident or something that, happened recently. We can also work with birth trauma. I've worked with a lot of new moms who, kind of had their, healthy pregnancy and, kind of had their birth plan, everything was all sorted out. And, as they approach giving birth, maybe they have some complications that arise unexpectedly, and they have to experience different interventions, and they don't know what the outcome is going to be and how long this is going to last, and is their baby okay? And so they hold all of these little micro traumas in their bodies, and it often leads to postpartum anxiety and depression. So with EMDR, we can go back in and kind of weave this cohesive narrative of, okay, and then what happened? The baby's heart rate went down. Okay, and then what happened? Oh, they had to, put all kinds of monitors on me. Okay, and then what happened? And then ultimately you get to the end of the experience of the sequence where, in most cases where, the birth occurs, the baby is fine, mom is fine. And so then we have this kind of cohesive narrative that includes all the scary parts, but it weaves in the ultimate outcome. And so really, ideally, what we're doing with EMDR is we're taking traumatic memory and we're shifting how a person is holding it. And so I always say to folks because it is a little confusing to explain what this is and how it works. But I say we can't change a memory. A memory is a memory. It's always going to exist. But we can change how the body is holding it. So another example to kind of illustrate that point is, how children hold traumatic memory. So kids, let's say, a trauma happens to a 5-year-old. A 5-year-old is going to internalize the experience far differently from an adult. So sometimes I work with adults who had childhood trauma. And so we're able to go from, some people say, is this like hypnosis? Well, it's kind of I call it a cousin of hypnosis, but you're never outside of awareness of present moment, of who you are in the moment. And so with childhood trauma, we have dual awareness. We're in the adult self, but we're able to also go back into traumatic memory and into the younger self. And so with that dual awareness, we're able to kind of shine a light on the childhood trauma from the adult perspective. Sometimes children walk away from a trauma feeling anything from the world isn't safe, I'm unlovable, I'm never gonna recover from this. And the adult can come in and say, of course you're lovable, and we're gonna keep you safe. And we can bring in all that's real and true, and it just really soothes the memory, the childhood traumatic memory, and it gives the adult a sense of, I really tended, like this wound has really been tended to. And so then when the adult is walking through life and experiences a trigger, because triggers happen, maybe a trigger back to the childhood wound, instead of falling into a deep hole of despair or activation or PTSD, most people report, yeah, the ouch is still there. I still have that distressing memory, but it doesn't take me down. I have this feeling that I've really tended to it and I'm okay. And I can come back to present and just move on. It doesn't have the effect it used to have on me. So that is, those are a couple of examples of how we can change how we're holding trauma in our bodies. And, I recently received a referral to do some EMDR with a man who was inside the Capitol while it was being attacked. He's a family member of a congressman, and he was there. And so he's reaching out saying, this was absolutely horrifying. I can't sleep. I'm having nightmares. I'm in a hypervigilant state. Like these are all telltale signs of, of a traumatic reaction. So that's another way we can use EMDR. With this man, his trauma is recent. We're not talking about past trauma. This is a recent traumatic event. So there's a completely different protocol to use with someone who's come out of a traumatic event like that. And again, it does this kind of weaving of, it's kind of like if you're looking at a heart rate monitor with all these blips on the screen. That's what trauma can look like. And so, an example might be, from this man at the Capitol. I was really excited. I was at the Capitol. This was going to be a historic day, and I was so fortunate to be there. And then all of a sudden, here's the spike. Mayhem broke out, and I couldn't believe what was happening. I thought, is this really, is this truly happening? Am I going to survive this? And so, more blips. And then now he's home and knows that it's over and he knows the outcome. But inside his body, he is still feeling all the activation of being there. So, so our plan is to do some of that weaving of telling the story, hanging out with the activation, going to the next difficult spot, hanging out with the activation, until we get to the end, until the whole narrative is one cohesive narrative. It doesn't have a bunch of hot spots in it. It's one cohesive narrative. And another piece that I'll add is that EMDR provides a safe sense of structure to do very edgy, scary sometimes, emotional work. Sometimes people are like, I don't want to open up that can of worms. Are you kidding me? And I always tell them, with EMDR, it's very, we're doing this the work is approached in a very purposeful, intentional way. And before we even do the work, we create a whole lot of safety. There's a lot of work done to prepare a client to really feel protected and loved and safe before moving into a trauma. And there's a lot of assessment that goes into play before doing the work to even assess the readiness of any given person. Not everybody's ready to just dive into the epicenter of something really difficult. And there are ways of working, kind of slowly working in the direction of doing the more intense work. And so, as you can see, I kept very excited to talk about this because it's not that it's for everybody. It isn't, but it can be very, very helpful for people who feel stuck in life, who can either identify specific traumas, or sometimes we don't even know what trauma we're going to identify. We work with a something that you might be struggling with just in your everyday life at work or that kind of thing, and we can kind of trace it back to a past trauma. So there are different ways of working with it. but I will, I'll wrap up now because I know we're going to have time for questions at the end. But thank you so much for letting me talk a little bit about this.
Thanks, Megan. I'm definitely going to have some more questions for you at the end. Okay, thanks, Meg. Hi, Jody. I think you're muted. Get you unmuted.
Hi, Bonnie.
Hi, Jody.
Very good to see you.
Very good to see you too, and I'm so glad you're here tonight.
And thank you for inviting me.
Thanks for coming.
Mm-hmm.
So you are going to share with us about somatic experiencing, one of the most favorite of modalities, along with EMDR too. And one of the things that we had talked about was you sharing with us a little bit about how Dr. Peter Levine, when he was conceptualizing this work, his work in observing animals.
Yeah.
How so much of this came to pass, how it was a derivative of that. And I'd love it if you would kind of start us off from there and tell us a little bit more about how this all got started and where it is now.
Well, Bonnie, you're starting with my most favorite way to begin talking about SE. So thank you for that. Yeah.
Thank you for that.
Yeah. And it's just lovely to be here. So I also, like Meg, get very excited about talking about my work in the SE, the somatic experiencing. So Dr. Peter Levine used to study animals in the wild, and he did this for close to 20 years. And one of the things that he observed is when an animal, so there's the predator and prey. And so when the prey is being chased by the predator, and eventually if the prey gets away, the prey will go find a safe place, and then it will begin to look around to make sure that it's safe. So they're orienting, and then it will shake, and it will let its body shake and shake and shake and shake and shake. And so what Dr. Levine observed was that what the animal is doing is shaking off all of the survival energy it took to escape from being eaten, the fight-flight response. And he observed this over and over and over again, and came into this relationship that with people, what we do is we go through some really scary event, and then we just, like some people have a car accident, they get up and they walk away from the car accident, and then they just go on with their life. But in there is all this survival energy that's been bound up from the accident. So Dr. Levine started going, so animals in the wild, if they successfully get away, they go to a safe space, they do this orienting to make sure there's no danger, then they shake it all, they shake off all this survival energy. So he started working with this idea that if animals in the wild can do it, then physiology is physiology. A nervous system is a nervous system. We should be able to begin to see how we can allow physiology to do the same. So he started developing this model called the somatic experiencing model, which is, it's a trauma-based model, and it's about working with these unresolved survival energies. We can like cry for help. We can fight our way out of something. We can run our way out of something, or we can go into what's called a freeze dissociation. So in my work, in the work that I do in my office, a lot of my clients come because there is some survival energy in there from either one event or many events that has bound in their system. And a lot of the ways that'll show up in my clients is like this unresolved anxiety, sleep issues, digestion, fatigue, irritability, relationship issues. And so the work I do is about helping complete these physiological responses. So how do I do that? I'm going to give you an example because I worked with somebody recently, and they came into, actually we were doing it over Zoom since the pandemic, and this person set their computer up in a room that they hadn't been working in for a long time. And so I always start off a session with doing, especially first time session, which this was, with doing a little bit of orientation, because this is how the animal brain, this little area back here, this animal brain orients to safe or unsafe. So I started off the session just asking him to look around and notice where he is, and da-da-da. And all of a sudden he started to smell something. And I said, "What are you noticing?" He's like, "Something's not right." And so he noticed there was this smell and he couldn't figure out where it is coming from. So he starts to orient to the danger, right? There's something wrong. He's orienting. It's the bed smells musty. I said, "Oh, what do you want to do about it?" He said, "I think I want to take the linen off and get it out of the room." Here's the fight response, right? There's an odor in the room that isn't working for him. He goes over to the bed, takes the bedding off, and takes it out of the room, comes back. I said, "How is that?" He goes, "It's better." He starts orienting again, safety or danger. He goes, "Something's still not right." This time he went and opened the windows, came back in and sat down, and he said, "That's better. Still not right." I said, "Oh, okay. What do you want to do next?" He picked up his computer and went to another room. Now we're in the flight response. Right? It was so amazing. So he takes his computer and walks from room to room to room till he found this room where he felt this was where he could work. Sat down, and I said, "Okay, now looking around." He goes, "Okay. Smells in here are okay. As I look around, things feel okay." And I said, "And what does this experience that we're doing remind you of?" Well, he had somewhere in his past a time where he was in a room where there were noxious fumes. And so the work we did in the session was about giving him options that he may not have had back then when he was smelling the noxious fumes in this past event. So it was really incredible to spend this kind of time exploring options, because trauma really is about the lack of options. Trauma happens, it's either too quick, too fast, not enough time. And so in my client's previous experience, didn't have enough time to get out of the room that was noxious. And so in this experience, we just really got to play out being able to come into that relationship. So yeah, I get really excited about that, because that came out of his own impulses. So in SE, it's this beautiful way of coming into relationship about the impulses that may not have been able to been complete during an event, or they were thwarted. Like sometimes little kids will reach for something and the parent will say no, and they'll reach for something and they'll say no, and they'll reach for something and they'll say no. Pretty soon the little kid learns to just not reach, right? So that's a thwarted movement. And so this work that I do with my clients is about finding some of those impulses that were either thwarted or that it happened too quick, too fast, that they weren't able to complete. Yeah. What else do I want to say? One of the things I learned from Peter Levine, Dr. Levine, is that trauma happens in the body, not in the event. And when I heard him say that, I was like, trauma happens in the body, not in the event. Wow. So the what happens, the event is over, and yet the physiology is still expressing these underlying responses. So somebody may come in that had let's say, a car accident, and let's say the car accident happened, the car was coming from the left, and they didn't see it coming. So when they come in to see me, and I do that little bit of orientation I was telling you about, and I observe them, and they never look to the left. They never look to the left. They never look to the left. And so then we get to begin to work with that response, like slowly imagining what it might be like to look over to the left, and then tracking how the physiology responds. How does the nervous system, how does the body respond when it imagines looking to where that car was coming? Sometimes there's a tremendous amount of activation, and sometimes there's almost like a dissociation, like I never saw it coming, so I don't even want to look. And so we begin to slowly rework that vortex, that vector where that didn't come, tracking the physiology so that they can have that full movement of beginning to be able to perceive and see the world from both sides, right? Because that's what I call in my work a little bit of a blind spot. So, but also in that scenario of a car accident that came from the left, what was the missing thing that wanted to happen? And so for one of my clients, it was, she wanted to be able to put her arms up and be able to push the car back. Physically, we know we can't do that, but that's what wanted to happen. She knows that in that moment, there was no time for that. But when we go back in and we start to use a little bit of the narrative and then use the physiology as a way to explore, when I asked her after we opened this left side back up, I said, what did your body want to do when it knew the car was coming? And she turned and she went like this and she said, stop. So there's the fight response, right? And we get to work, she got to work with that over and over and over again until the physiology, until her nervous system didn't keep responding as though the event was happening right now. It's really it's really amazing to sit with somebody and watch them come out of what I call, it's like frozen in a state back in time, and watch them come out into real time and be able to work with completing something that, again, there wasn't enough time. It happened too fast, right? Even though she wouldn't have been able to do that back then, in the imagination, that's the way the system can, one of the ways the nervous system can complete. Yeah. Yeah. Hmm. Hey, Bonnie.
Hi, Jody. I love listening to you talk about this, and I love listening to Meg too. I'm also a psychotherapist, as was mentioned earlier in the program, and one of my specialties is trauma. Mm-hmm. And the reason that I get so excited about talking about all of this is because when I describe trauma to clients, I often say it is time travel. Mm-hmm. And you're sitting in this room, but you're back in 1976.
Right.
Your body is feeling what it's feeling in 1983 or 1992 right. or January 6th, 2021. But wherever you are, your body is experiencing whatever it was
right.
on that day, and you've been hijacked.
That's right.
And your system is not, it's in this room, but it's not really in this room.
That's right.
One of the reasons that I was very happy with NAMI's innovation in creating this program was that so many people don't know that the ways that we actually get our bodies back in this room, and we finally get to come back from 1976. We finally get to return from 1983 on a really horrible day, or January 1st. Yeah. January 6th, 2021, which is such a gift that Meg gets to participate in.
That's right.
Is who knew that turning to push a car back, that you weren't really going to push back, but getting to do that was going to unwind and rewire this person's body so that post-traumatic stress could be released.
That's right, Bonnie. Very well said.
And so one of the things that I've learned in my years of working with trauma is talk therapy does not heal trauma.
No.
In fact, talk therapy can strengthen traumatic responses in people's bodies.
Yeah.
And these somatic-based, which means body-based approaches, and approaches like neurofeedback, which is a brain-based approach, is how the body gets to release trauma. And that's something important that I want the audience to know.
Yeah.
That these approaches, though they may seem different or novel or maybe even strange to the audience, they work the trauma out of the body. Because as Joe said, the trauma lives in our bodies. And that's why when we get hijacked from back into the event, we feel it in our bodies.
That's right.
The racing heart, and we have the nightmare, and we feel like we're in that moment.
That's right. Yeah.
These movements, and as Meg was talking about, the way we work through these things gets us, it unwires it.
And brings us back into the present moment, right?
Yes.
Right. Because so many of these experiences, we're not actually here. We're back there as though it's still happening back then, right? And so the more we can work with some of these responses, it allows us to become more present right here, right now, what is happening, right? The car accident isn't happening. Those noxious fumes, although he did smell must in his room, was not the poison that was happening back then, right? And with the example of the smells, him being able to take this stuff out and get it out of the room was what he wanted to do back then, so that he could come back into this moment right here, right now. I'm okay.
Right.
The event is over. I was able to do something to protect myself this time. Yeah.
Right.
Yeah.
And all of these healing experiences really rewire our bodies.
Yeah.
It really takes an unwiring and a rewiring for us to get home to the present moment.
That's right. That's right.
From.
Yeah. Yeah.
So,
thank you.
Thank you.
Thank you.
Thank you. Okay. And so now we are going to move on to Dr. Lagarda, Dr. Stella Lagarda. Is she here with us?
Yes.
Yay, Dr. Lagarda, my favorite neurologist.
How are you, Bonnie?
Hello, dear Dr. Lagarda. It's good to see you tonight. Thank you.
You too.
Thank you so much. So,
okay.
As everyone here knows, you're here to share with us about neurofeedback. And I'd love it if you would share a little bit about it, obviously its benefits. And if you would share, one of the big questions I always get is, how does it work? And some of the differences in the types of neurofeedback. And I know that you're the one who has brought neurofeedback into CHOMP, into the medical community here on our peninsula. And I'd love to hear from you a little bit about why you've chosen the type of neurofeedback that you've brought into the medical community here, and just benefits and how you can see this just helping people neurologically, people that have mental health conditions. You and I had personally talked a little bit about trauma. You certainly work in the field of neurological disorders, and if you could just flesh it out a little bit for us, that would be great.
Thank you, Bonnie, and thank you to the NAMI Beyond Medication and the Voices of Monterey for, I think, a very important presentation. It says I can share my screen. Shall I go ahead and do that for the slides? I was told somebody else would be handling the slides, but I'll be, okay, good. Thank you. So this is an introduction to infra-low frequency or ILF brain training. And as Bonnie was saying, this is the preferred neurofeedback modality that I have adopted in my practice. Very late in my career, I've been a career neurologist, epileptologist, and kind of reinvented my practice in 2013 because of this modality. So what does brain training actually mean? We're actually doing neuromodulation or brain network learning. So when you see me using these terms, they're actually interchangeable. And there are different forms of neuromodulation. Next slide, please. So before we can talk about the brain and neuromodulation, we have to understand that neuromodulation is actually network learning, network physiology that is being addressed. And so I wanted to make sure we were all on the same page regarding what a network means. So think of your computer and think of your email address. Each node, each computer, wherever you send your message from is the IP address, is that computer. And then the lines connect the nodes, that computer, to whoever you're sending your email message to, whether it be .com, .org, .net. You could see here that the green ones are .com, .org, dark blue goes to .net and .ca and .us, and the red are regarding the military, government, and EDU ways of communicating. Now, the lines indicate the delay, and the color indicates the source. So the longer the line, the longer the time it takes from one IP address to another, or each one node to the other node. Now take note, some nodes are like stars. They're pretty big. They're bigger than other nodes. And when a node becomes very connected and highly connected, it's called a hub. And so that's what a network is. It's a bunch of hubs and nodes that communicate constantly. Next, please. So let's look at airports in America. This is a nice picture of all the airports in Northern America. And you can see the hubs clearly here in Los Angeles, San Francisco, in Miami, and Texas, and the Northeast is just one major big hub at this distance. But this is where the analogy between hubs and brain hubs or network hubs disappears, because as you know, when we go flying on an airplane, we like to fly from hub to hub, and so that we avoid all the major little connections. In the brain, it's different. The hubs have no, you can go on, that's good. In the brain, it's very different. The hubs are very poorly interconnected because this is the way nature organizes networks. The hubs don't connect to each other in case of an infection, in case of a viral infection, and one hub gets put out of commission. Therefore, the other hubs maintain their strength and their integrity, and the nodes around just have to get to where they need to get around the hub a different way. And then click once, please. That's as opposed to a random network, which is where you see one node has very few connections. What we have here in the brain is called a scale-free network. So think when I'm saying network, you got to think a scale-free network where we have a lot of hubs and less of the nodes as much in terms of the organization of certain skills in the brain. Okay, next. All right, so here's our beautiful brain, and you can see all the major hubs. There are a lot of them, and the thick lines are all the connections. The thinner lines have less connections. And then the next slide. This is an excellent study done just with EEG, and this individual, Dr. I've forgotten his name now, Dr. Thatcher, yes, he found, he looked at children based on their IQs, okay, and he looked at the morphology of the EEG recording on their routine EEGs, and he looked at the differences between them in terms of EEG characteristics. And what he found was that children with higher IQ actually had a small world efficiency. They were very self-sufficient at the hub level. Yes, they had connections to distant locations, but they were much fewer, and it was more of a self-reliant dynamic going on. Kind of like humans, we all like to regulate and have our own homes and families and be in control of our own lives. But yes, we have connections to our communities and to the environment. Those with lower IQ, however, had poor self-regulation in the hubs, and they needed longer distance connections to other hubs in the brain to perform their function. Yes, they had some self-regulation, but it was difficult. So they required a lot on long distance processing skills to perform the activity. So neuromodulation is based on the scale-free network and small world theory. And this is how I'm going to explain what happens in neurofeedback. Next, please. So how do we perform neuromodulation in neurology practice? I'm presenting this in terms of exogenous neuromodulation and endogenous neuromodulation. So you can see with exogenous neuromodulation, these are device-derived regulation, and you have seen them in terms of the vagus nerve stimulation, deep brain stimulation, and responsive nerve stimulation. One click, please. And you can see the vagus nerve stimulation is this device in the neck. It acts as like a pacemaker in the brain. Another click, please. Then here is the responsive nerve stimulation. The VNS, for example, acts like modeling in psychological terms. The pacemaker creates a new network that is very regular, very reliable, and the brain is kind of modeling after this and getting away from the epileptic network. The VNS also comes with a magnet, which the patient can apply to the VNS and apply a bigger shock randomly to stop a seizure when it's coming, when the patient feels a seizure coming. And that is, of course, behavioral therapy, Skinner, right? Negative reinforcement. And then the RNS on the other side, or responsive nerve stimulation, is all Skinnerian. In this model, the device is in the cranium, and there are electrodes around the brain, and it's constantly recording the brain here. Here's the EEG, and when it sees a seizure coming, then zap, very Skinnerian. It's just modeling. It's neuromodulation. It's neuroplasticity. It's training the brain. Okay, it's training the brain to behave another way. And then there's endogenous neuromodulation, and this is where neurofeedback comes in, because it's based on computer-brain interface-derived self-regulation, and it's either formal conscious learning, and this is the traditional neurobiofeedback methods, or limbic subconscious learning. The consciousness is taken out of our patients, and this is infralow frequency neurofeedback. And that's very important, because we need to learn how to get out of our own way, as I'm speaking to the audience here. And I find ILF neurofeedback powerful in doing this. Next, please. And here is what it looks like. The patient sits in the chair and watches a video, and while he's sitting there, we record his EEG from his brain, which is amplified by the neuroamplifier and comes to my computer. The computer processes the brain signals coming from the brain. It inhibits some, throws out some, and promotes the ones that we want. It promotes the frequencies we want, and returns those promoted frequencies to the video he is watching. And then the loop starts and ends with the client. The client now, there's a part of his brain subconsciously that knows it affects the video and the audio coming out of that movie he's watching. So the brain now starts making those promoted frequencies, knowing instinctively that's what's driving the video audio that its host client consciously is intent on watching. Next, please. So look at the outcomes here on the responsive nerve stimulation. And again, just to remind you, that's the device that just records and then provides a zap when it picks up a seizure. Look at year 3. It takes years for the brain to train. But once it starts learning, once those tracts are learned down, here we have 45% seizure freedom, and at 8 years, there's 73% seizure freedom. So it's very powerful stuff that we can actually train brain activity, train brain behavior through EEG, which is our only access to the brain right now. Next, please. So the evolution of neurofeedback brain training. So as you know, in psychology, it all starts with classical conditioning, autonomic salivation with the bell and the food in Pavlov's dog. So with autonomic training, we then evolved to operant conditioning. That was classical conditioning. Then we went to operant conditioning, which was Skinner's method of reward and punishment to get the behaviors we wanted. And, you know, we still use this in our raising of children sometimes. And then Barry Sturman looked at this and said, well, I want to prove that I can train EEG, I can train brain behavior. And the way I'm going to train brain behavior is through the EEG. So what he did was he got a bunch of cats, and this is the EEG. And every time they were in cages, and every time they went into this relaxed mode of SMR or somatic motor rhythm, which is like a high alpha rhythm, a door would open up in their cage and they would get soup or milk. They got a reward. To cut a long story short, soon enough, he had a whole bunch of cats all in this state, and he wrote up his experiment and he put it away. And he put the cats back with all the other cats. Now, next click, please. As serendipity would have it, he was working at NASA, and NASA asked him to look at the toxic effects of propylene glycol, rocket fuel, monomethyl hydrazine, sorry, which is rocket fuel. And the end point was going to be seizures. And they wanted to know how much would get to that endpoint and how much would be toxic to the astronauts. So he did it on his cats, and he kept having problems with his results. There were these bunch of cats that just would not have a seizure. They just wouldn't have a seizure, and he didn't know what was going on. He repeated his testing, and he still got the same result, and it was always the same bunch of cats. So he looked in his logbooks to see what he had done with these cats. Well, guess what? Each and every one of them had had this training, this SMR training. Therefore, he started thinking we should do this in humans, especially humans with epilepsy, since he was able to prevent seizures, which other cats were having at toxic levels of the rocket fuel. Next, please. So now that's traditional neurofeedback training in the alpha spectrum of the EEG. Enter the Othmer method. The Othmers, Siegfried and Sue Othmer, are just these amazing people who set up shop, and they were doing the SMR training, but they started doing it patient-based versus doing it on the patient's response to the training, as opposed to expecting the patient to respond to whatever the clinician gave them. So they were very receptive to their clients' responses, and they decided to see if lower frequencies might even be beneficial, because they made a mistake one time in the lab, and a patient said, oh no, leave it right there, because they had left it too high up on the bar. And the patient said, oh no, leave it up there. And the patient really liked it. And he did really well. And so they started looking at other patients, and soon enough, all their patients were clustering down here, and so on. So today, the frequency of training has gone all the way down to 0.0001 millihertz. I'm talking millihertz, not just hertz, okay? Completely outside the usual EEG spectrum that we record. And at this frequency, at these very low frequencies, what they were finding, what were all the symptoms that patients were presenting with, they were all resolving over months to levels that were either comparative with norms or completely comparative with a better quality of life. And you could see all the symptoms there. Next, please. So basically, I joined them in 2011, and the proposed mechanism was that when we do neurofeedback at these very, very slow frequencies, we are engaging the known biological, very slow frequencies that are understood to modulate cortical excitability, or in other words, regulation. So these very low frequencies can be recorded, and they are called infraslow oscillations. They are oscillations. And it has been found by some researchers looking at these infraslow oscillations that they do not come from the neurons, but they come from astrocytic function, probably from the ATP that is derived from astrocytes. Now, we all know the importance of astrocytes in, guess what, synaptogenesis. And synapses are all about learning, synaptic plasticity, homeostatic plasticity of the brain. And then the anatomic density and the position of these astrocytes make them, put them in a strategic location in the brain such that they actually perform hub functions. Next, please. So neurons are dependent on the astrocytes. A single astrocyte enwraps over 1 million synapses. An astrocyte has at least one process with entity in blood vessels. There are, every astrocyte has a unique territory and is involved in network signaling, not just signaling to the neurons that it has trophic support for, but actually extending that signaling throughout the network. So basically, at the very bottom line here is what I want you to read. Dysregulation of the astrocyte neuron coupling is what gives rise to neurodegeneration. Next, please. Now, before I go any further, this is endogenous neuromodulation, the Othmer method. I'd like to quote Dr. Othmer, Siegfried Othmer, about everything that you've been talking about today here in this conference, which is wonderful, and I feel very glad you invited me to talk. This is Dr. Othmer's words, quote, "In retrospect, much of our 36-year developmental trajectory in neurofeedback could be well described under the general theme of trauma recovery. At every point along the way, we were challenged by the clients that were refractory to our conventional approaches. Over time, it became clear that this clinical frontier was largely populated by those who had suffered either emotional or physical trauma, or both, early in life. Progressively, this factor came to determine the clinical approach to the affected cases, irrespective of the age at which we encountered them. Therefore, a multifaceted clinical approach has emerged, one that places the greatest reliance on resolution of the physiological constraints on trauma resolution. And it is now our expectation, once those physiological constraints are relieved, the classic trauma-based categories, such as PTSD, no longer reach that diagnostic threshold. And that is what our colleagues are doing with their forms of neuromodulation as well. It's all neuromodulation. Next, please. Oh, sorry. Here, let's stay here. So basically, here's in bigger picture of what we're doing. And again, I call it a second generation neurofeedback because it's gone away from the usual SMR training. Next, please. And this is the optimal reinforcement frequency. This is where the patient reports where they feel really good, and that is the frequency they stay at throughout the training. Today, however, our training has become so much in the lower realms that we actually just go slowly lower and lower in our training until the patients have a problem, and then we just stop right there. Next, please. Hello? Okay, this is one of our last slides. So endogenous neuromodulation, at least in terms of the infralow frequency neurofeedback brain training, engages the infraslow oscillations. And the ISO is a very important feature of resting state networks. You've all heard of the default mode network, the salience network, the central executive network. These networks are our alert resting state networks when we are awake. They are always monitoring our environment and working towards creating a response to our environment. And next, please. These resting state networks, the default mode network particularly, are disrupted in patients with PTSD, chronic traumatic encephalopathy, Alzheimer's, and autism spectrum disorders, and probably in all other diagnostic categories that give rise to the same spectrum of signs and symptoms in our patients. Next, please. Not only that, we also have neuropsychological and functional brain mapping. We know that patients may present with OCD, ADHD, depression, and anxiety is a big one, cognitive decline. And we know we can help these patients by choosing the right geography on the brain in which to perform infralow frequency brain training. And I'll stop there for any questions. Thank you.
Thank you, Dr. Lagarda. I appreciate you taking the time and providing the slides. So I imagine people are going to have a lot of questions about all of this. We've provided 3 very different types of modalities. And the nice thing is we have all 3 of these offered here on the peninsula. And I know that Joe has quite a few questions that are coming through from the audience. And I have some additional questions just about the modalities to just deepen and enrich what they've already shared with us. But Joe, let's start with the audience and find out what they would like.
Yeah, thank you, Bonnie. There were lots of terrific questions today, and it's what I like about this this format too. Is that this is becoming sort of a conversation more than listening to lectures. And so someone asked, and this is for Meg, I guess, does EMDR work for survivors of child sexual abuse?
Sorry, Joe. I just needed to unmute myself. Yes,
Yeah.
it is an appropriate modality for childhood sexual abuse. Absolutely.
Another one, as long as we have you on the line, can EMDR help root out the trigger mechanism in manic episodes?
That's a really good question.
Yeah.
That's a really good question. I cannot speak to that as well as I would like to. Although I do know, the trigger mechanisms just in general, just general triggers can certainly be worked with and rooted out. But I can't really speak to manic episodes. To
Joe,
explore that, or maybe ask Bonnie. Yeah.
One of the things that I can speak to around that, and Jody, you might want to pipe in here too, is continued mindfulness practice will really work to do the brain training, to build the mid-prefrontal cortex and allow the brain to have less reactivity when those triggers come in. And that continued practice will be of great assistance to people. And that is also deeply evidence-based, and that will help people learn to manage the triggers. In doing the EMDR, when people do get triggered, will help decrease the intensity of the reactivity when the trauma is lit up in the brain. But working with the triggers around mindfulness will help build the brain strength. Jody, do you have any thoughts on that?
Well, not to the mania itself to speak to that, but what you're speaking about, Bonnie, is, like sometimes SE and mindfulness together, or mindfulness and EMDR, where you're really allowing yourself to come into the present moment and track what's happening, and being able to, whether it's with yourself, if you've had enough experience with it, or with another practitioner or therapist, be able to begin to open up the response a little bit, because sometimes the responses happen so quickly. And so the mindfulness and either SE or EMDR or the neurofeedback, how do you start to slow that down enough and come into relationship so that you can have another option to it?
And because we don't have mindfulness here on the panel tonight, and so many people watching this may be familiar with mindfulness and many may not be. If that is something you would like more information on, I will provide NAMI. I will give my number. I'll make sure NAMI has my number, and you're welcome to reach out to me by email. And I'm glad to give you some resources on mindfulness-based practices and how to get involved in that.
Thank you, Bonnie. I have another question here that sort of goes to what we're all facing right now. Someone asked or said, teletherapy and these particular modalities, how can they be performed in the age of COVID without in-person, face-to-face interaction? Has this been a challenge for each of our panelists?
Yeah, I can briefly respond to that. I'm really glad that question came through. Fortunately and surprisingly, to many EMDR practitioners, EMDR can be, not always, it's not, there are often contraindications, but many times EMDR can be performed over teletherapy, and I'm doing it, and it's very successful, and yeah, so we're able to do that during this time.
Yeah. When COVID first started, Laurel Parnell, Meg is on the faculty of the Parnell Institute, and Laurel Parnell teaches a particular type of EMDR, which is a focused EMDR. And so it focuses a lot on interpersonal trauma. And so she did a training on how to do online EMDR. So a lot of us have had actual training on how to do it online. So we're not winging it. We've been studying it. So it's out there, and it does work.
Anybody else want to weigh in on that, Jody? Dr. Lagarde?
Well, we have to have patients come in, and everybody's masked. And the thing is, we don't stay in the room with the patient, and we don't allow many people in the room with the patient at all, one additional provider. So it's all very distance oriented, very brief changing of electrodes, and that technician is out of there. Their driver waits out in the car. If there's, it's all very careful. We haven't had any problems with COVID outbreaks in our clinic. So.
Good, thank you. There's another question that came up when Jody was speaking, from someone who says, and this was a statement posed as a question here, you almost have to relive the traumatic event in order to heal? Question mark?
No.
Okay.
No. That's a really, really good question. So in the work that I do, it's telling a little bit of the narrative, kind of like if you could imagine like the New York Times headline version of the event, maybe not even that much. it's just enough of the narrative to begin to track physiologically how the body's responding. Like, Joe, if you were starting to tell me a story about something, I might observe how your shoulder starts to raise when you talk about something, or how the color in your face starts to change, or you start to hold your breath. Those are all physiological responses by you just sharing like just a tiny little bit of something. So it's really not about going in and going through the whole event. It's really just that small little snippet. Go in and do a piece of work. Downregulate what the responses are. Another little snippet. It's kind of like Meg was talking about in a similar kind of way, right? So that you're threading the narrative together, and each time you're doing it, you're de-escalating the system a little bit more each time.
Mm-hmm. Mm-hmm. And I would add, because this question comes up a lot in my work, my EMDR work, do I have to relive the whole incident? And very similar to how Jody's explaining, it can be a portion of the incident. It can be experienced without sharing it out loud. It can, when working with a recent traumatic event, I usually ask the person to tell me the story in its entirety one time. And then, they're just kind of replaying portions of it to themselves. But it's not the retelling and the reenactment and the traumatization of the event. And this is where there is so much. What we're not going into detail is around the care and the pacing and the preparation. We wouldn't just dive in to a trauma. It's very mindful. It's very gentle. It's very purposeful. And when I say gentle, more like caring. The client is held, so to speak, in the therapeutic space with a lot of safety and a lot of care and holding.
Yeah, I'd like to say something about that. The infralow frequency brain training releases the physiologic constraints that have been built up because of that event, the trauma event. We don't really care what the event is. We know there have been physiological, Jody said, the trauma occurs in the body, not in the person. We know trauma has happened in the body, and that's what the ILF does. Now, holding that person in a safe space is another form of neurofeedback. We call it alpha theta training, where they are suspended in this not quite fully alert, neither are they drowsy. They're like alpha theta. And with meditated guidance, you can see patients just release anything that they were worried about. They can bring up their stuff that they didn't want to bring up before, and they're detached from it, and they feel safe in that stage. So that's where neurofeedback, alpha theta training is also beneficial.
And I just want to jump on what you just said, Dr. Lagarda, is the detachment. So I think one of the threads, the similar threads that we're talking about here, is we're taking a subjective experience and moving it outside, moving it into the objective, where it's observed from distance with safety and that kind of thing.
Good. Thank you. I have a question about access that I think I can ask all of you. But before I do that, I'd like to do a quick shout out to Julie Reynolds Martinez, who is our producer tonight. She's doing a fabulous job, and I want to thank you, Julie. Julie's with Voices of Monterey Bay. She's the brains of the operation.
Joe,
yeah.
Just on that theme of Julie, there's a note here that says, Joe, please remind the audience that they can watch this again at vomb.org/NAMI.
That's right. This will always be available. This will be available online. And all our panelists are free to share. Everyone's please share this as much as you can through. We'll be posting it also on NAMI.org. So that this hopefully will get wide circulation. The question I had was, and I'm going to piggyback on this question with one of my own too, because it's both about access, is what diagnostic modalities like advanced EEG techniques and fMRI available in our area, and are they readily available to clinicians? And then I wanted to ask, is there a way a person with limited means can have access or can gain access to any of these treatments?
I don't want to make anyone, my neurofeedback colleagues in the community, there are quite a few, not ILF, but they do the SMR training or brain paint, which is another, and I would refer the audience to them, that they're very good. I see really physiologically affected people as a neurologist. So I'm dealing with a lot of stroke, epilepsy, migraines. Access to me, though, is depending on how severe you are. The more severe you are, the more likely you'll be seen. I see the children of field workers, people who work in the field, they have no money, and they pay, I allow a minimum. The system has allowed me to charge a very minimum self-pay for these individuals, for their children, for cognitive difficulties or very bad epilepsy. And it's so powerful that it's worth the money if insurance doesn't pay for it. But we do not, clients with predominantly psychological disorders, I get this a lot. I wish I could fling open my doors and invite everybody in, but right now I only have 2 rooms, and I am opening up 2 more rooms. We will have 4 rooms, but it's really busy. My waiting time is till November, and when those 2 rooms open up, hopefully that will go up, and then I'm hoping at that time we'll be able to accommodate the most severe psychiatric patients, but they have to be referred by a psychiatrist who is helping me manage it.
Right. Thank you.
Mm-hmm. Yeah. As far as access, go ahead.
No, you go ahead. Was that Meg? Yes, go ahead.
Yes. Yeah. As far as accessing EMDR, this community has many EMDR clinicians in private practice. And I've had the great fortune to be able to provide consultation to many of them. It's so rare to be able to know how a fellow therapist works, but I have firsthand knowledge of several high caliber EMDR clinicians in the community. And so they're, on various insurance panels and the like. Yeah.
Yeah, we were talking today in a consultation group. Actually happened to be in that meeting with Meg, and we were talking about available referrals. And there are a number of nonprofits also that do have interns and other therapists that do EMDR. We were talking about the Monterey Rape Crisis Center right now. We know there's someone there that's practicing. So there are some low cost places that do offer it.
And again, on referrals, I mean, it's important to get the referral from your private physician or psychiatrist, right?
No, you don't always have to.
Okay.
With neurofeedback, the hospital, yes, but not for EMDR. I mean, you could, if someone, for instance, had a sexual trauma and called the Monterey Rape Crisis Center, they could. And I don't know. Sorry, someone else spoke.
I just said people can self-refer.
They can self-refer.
Okay,
Yeah.
gotcha.
Really local centers, and it's certainly worth calling, the YWCA, Shine a Light. There are numerous really good centers that offer discounts and often offer numerous alternative therapies as well.
Bonnie, do you have any questions of the panel? We don't have a whole lot of time left, but
one of the questions that I wanted to offer to Meg and Jody, one of the things that both of you bring into your work that's so foundational to trauma survivors is resourcing and resilience building. And because, and you both touched on this a little bit, because people that are walking in that are really severely traumatized, there is usually so much terror. And people don't feel into their body. So if you could just share with our audience a little bit about what resourcing and building resilience might be, just to help them know how they would feel safe moving into this kind of work with you guys.
It's a great question. Do you want to go first, Meg?
Sure. When we were talking earlier about, do we jump right into trauma? No, we assess each client that we're working with and pace the work. But one thing I do with everybody I work with, whether I'm doing EMDR or not, is this process called resourcing. And it's very, it is foundational for not just for trauma work, but for grounding and just kind of getting back into one's body in a safe way, finding safe resources that already exist within the person, from nurturing figures, animals, people that make you feel loved, animals that make you feel loved, animals and people that make you feel protected. And so we're kind of eliciting, or we're calling forth these feelings, and there's a somatic component of really kind of noticing how it shows up in your body when you think of these resources, and then kind of EMDR style, we tap it in. And so, oftentimes people just give themselves a hug and tap on their arms. And this is the bilateral stimulation. And it's just very soothing just to sit and tap your arms. There's a man, Bruce Perry. What is he? Is he a neurologist or? But I had always, I've always been curious, like, what is the mechanism, that kind of secret sauce in EMDR? And Bruce Perry, who studies, I think he's a neurobiologist. His best guess, and this is what resonates most with me, is that bilateral stimulation kind of brings us back into our first experience of being in the womb and hearing and feeling the rhythm of the mother's heartbeat. So, that brings us back into regulation. It brings us back into that first feeling of safety, of being held. So then, add in, snuggling with your dog that makes you feel loved and makes you feel, elicits your love and feelings of safety and connection and that kind of thing. And you're building all kinds of things. You're building inner safety, you're building resilience, and then for future trauma work, you're paving the way for that to feel really safe and contained.
Thanks, Meg. Great description.
Mm-hmm.
Great. Dr. Lagarda, I have a question for you that I think might be helpful for people. As people's brains start to learn, when people are thinking about sessions, how many sessions should people plan on, or how does that part of their treatment planning work?
Very good question. So it really depends on the degree of trauma. Some people have had a recent concussion and they feel great after 6 or 7 sessions because it's really powerful. And they say, I'm doing really good. I think I'm okay. They stop their medicines even and they say they're fine. But if their concussion happened over a year ago, 2 years ago, I recommend at least 20 neurofeedback sessions. We think there's an initial recentering, it's like the bell, the clanging bell I've told you about, and there's a recentering of that clapper in the middle of the bell right after the first session. But of course, it goes back when they go back to their usual activities, and then they come back again. And that reinforcement over time, it's like skill learning, right? It's learning a skill, putting down the pathways in the brain to go there on your own. And we think there's also a period of consolidation. You may get the skill, but then we want to consolidate it. And we know we're almost there when in between the sessions, the patients report just feeling good. When they feel good between the sessions, we know we're almost there. And then we say 10 more for consolidation, and that's it. If the sessions are twice a week, a lot of our patients come twice a week. There's a lot of reversals, but when they're feeling well between those weeks, it's really good. And then week to week and so on, just 10 more, it would be the consolidation phase.
Great. Thank you. Thank you. I know that's something that people are all very interested in, the time, the finance, the emotional commitment to all of this. So I appreciate you all speaking to that some. Well, we have come on 7:30, and I would like to say thank you so much for all of you sharing your knowledge and your passion. And even more than that, thank you for everybody that you touch.
Oh,
you guys make such a big difference in this community. You help so many people. That helps their families and everybody in their lives too. So, and I happen to know all of you personally, and I really appreciate your spirits, everything you put out here in this community. So thank you.
You're welcome, Bonnie.
What? I'm sorry?
I said you're welcome. Thank you.
And Joe Livernoy, thank you for everything you do for this community and for the NAMI board and for all the years you've put in. And to all board members for the vision that you guys have and how you just keep the boots on the ground, just helping consumers of mental health services and their families and their peers. And for everyone that works for a better mental health community here and just works to alleviate suffering and bring peace. And Julie, I want to thank you for all of your help this week and tonight. And for all of you watching, may you stay well, may you heal, and may tomorrow be even better than today. And for any resources or questions you have, NAMImonterey.org. I will be leaving my email address up at the office. Please feel free to reach out to me. My email address is Bonnie Buffkin, MFT, BONNIE, BUF like Frank, KIN like Nancy, MFT like Marriage Family Therapist at yahoo.com. And just let me know that you were a part of tonight, and I will get back to you and help you with any resources to the best of my ability. So everybody have a really blessed evening, and I hope to see you again. Thank you for joining us.
Thank you.
Good night.
Good night.
Good night.